Madhukar.
Good evening, ma'am.
Good evening. So you're, you know about the first case and all. We're still, Pramila, you're there?
I'm there.
Asmita, it's now, I think 5 minutes left.
Dr. Ganpati is yet to join, I suppose. He's not
I already opened the lodge at 7.
Okay. Okay.
A couple of things, ma'am. One, I don't have backup because internet is suspended in Jodhpur.
Because, okay.
So it's only my landline which is working, which I'm using. So if by chance there are also power cuts happening. So in between, if a power cut happens, usually what I do is I keep a hotspot open, but even that is not working today.
Why is it that? Because of security issues?
Yeah, there's been some clashes in the old city.
Oh,
So,
yeah, it came. Okay. For that.
So can, I think we...
that electricity goes off in between, it may take a 1 or 2 minute lag for me to get back online. So I just wanted to bring this to your notice.
You can start the video and then you just flash the flyer, the program flyer.
Are we online? Shall we start?
Yes.
Namaskar. The Indian Thyroid Society is a vibrant and inclusive platform for healthcare professionals who are passionate about the thyroid. We invite you to join us and make a difference in the science, research, knowledge, care, and advocacy in all things thyroid. We have context-sensitive continuing learning programs that address the needs of clinicians, trainees, and experts alike, on-site and online. Our flagship journal, Thyroid Research and Practice, with its short turnaround and all articles ahead of print format, is an ideal vehicle for your research publications. We invite you to join, participate, network, and grow with us. To know more about Indian Thyroid Society, visit the website www.indianthyroidsociety.in. Namaskar.
So we welcome you all to another episode of Thyroid Clinics, and it's an interesting session today lined up. We have 2 cases and we also have a quiz. So please stay because the quiz will be very interesting and there are prizes to be won for the quiz as well. So to start, I welcome our patrons, Dr. R.V. Jayakumar and Dr. K.M. Prasanna Kumar sir. And I welcome our president, Dr. Sarita Bajaj ma'am. And our chairperson for today is Dr. Ganpati Bantwal. He is professor and head of endocrinology at St. John's Medical College, Bangalore. He is the past president of Endocrine Society of India. So he will be taking us through to the program now. So I request Dr. Ganpati to introduce the moderator and carry forward the program.
Thank you, Dr. Pramila. Thank you, Dr. Sarita Bajaj, for inviting me to chair the session on this series of cases where we'll be discussing 2 very interesting cases and how to suspect them, those things. And the moderator for the session will be, can you just put it on the thing? Dr. Madhukar Mithil. He is the professor of endocrinology at Jodhpur Medical College, All India Institute of Medical Science, Jodhpur. So he'll be actually moderating these 2 sessions. Now I hand over the session to Dr. Madhukar to take on the proceedings.
Thank you, Dr. Ganpati Bantwal, sir. And I think we'll move ahead straight to the case. Dr. Lavanya is going to take us through an interesting case, and we can just go through in between with our queries and suggestions. Dr. Lavanya, please.
Yes, sir. Is my screen visible, sir? Sir, it's visible.
Yeah, slides are visible.
Yeah, it's visible.
Yes, please go ahead.
Good evening. I'm Dr. Lavanya Boni. I'm a DM resident from St. John's Medical College. Tonight, I'll be presenting a case of inappropriate TSH secretion. So, coming to the history, this case is about Mr. V, a 64-year-old male who presented to us with weight loss in 6 months. He was detected with abnormal thyroid function tests from outside and so was referred to us. That's how he presented to us. He had only a history of weight loss.
Sorry for interrupt, Dr. Lavanya. Can you please switch on your camera?
Sorry, sir.
Can you please on your camera?
When I share the screen, it goes off from my iPad. It goes off automatically, actually.
Okay. Okay, fine. You may continue.
Okay. A history of present illness. There was no history of palpitation, tremors, or increased sweating. No history of loss of appetite. There was no history of polyuria or polydipsia. There was no history of any chronic cough or fever, and no history of abdominal pain, melena, or hematochezia. Moving on to the past history, he had history of bilateral sensorineural hearing loss for last 10 years and was using hearing aid for the same. Other than that, there was no history, any other history of any other comorbidities. Moving on to the examination, he had a pulse rate of 102 per minute, regular, and a blood pressure of 98/64 millimeter of mercury. He was afebrile. On general examination, he had no pallor, icterus, cyanosis, clubbing, lymph node enlargement or pedal edema. He had no tremors or eye signs. He had a grade 1 goiter, which was firm, but there were no palpable nodules. Apart from that, the other system examination, including the respiratory system, CVS, GIT, and CNS, were all normal. So I'll summarize my history and examination. A 64-year-old male with no past history of any comorbidities came with the only complaint of weight loss since 6 months. On examination, he had resting tachycardia and goiter on examination. And he also was referred to us for abnormal TFT. So since he had a history of weight loss and he was elderly and with tachycardia and goiter, the first DD kept in mind should be hyperthyroidism. And probably since he had no overt features of androgenic excess, it can be apathetic hypothyroidism. Moving on to the investigation. So this was the first TFT that was thyroid function test that was done from outside. It showed a raised TSH of 10.1 and also raised total T4 and raised total T3. So this was not fitting into the usual log linear ratio between the thyroid hormones and TSH. So the first suspicion should definitely be a false report, a lab error, or some interfering substance. So falsely high total T3, T4, or maybe a falsely high TSH, which is why we had repeated thyroid function test again after including the free hormones also. So when he came to us, we repeated the thyroid function test again. That shows a high TSH again, 12.7, with raised total T4, total T3, FT3, and FT4 also. So since all the both thyrotropin as well as all the thyroid hormones were raised, this can be classified under inappropriate TS secretion because the thyroid TS is not suppressed as is expected when there are raised thyroid hormones. So the DDs that are kept in mind, both rare disorders, should be Tsh Oma versus resistant thyroid hormone.
So, Dr. Lavanya, if I may
Yes, sir.
So you gave us some history before you came to the investigations with regards to weight loss. So
Yes, sir.
any other things, I mean, before we move to the thyroid part, any other things which you would like to sort of ask for weight loss in this age?
Yes, sir. Weight loss. So at this age, definitely a malignancy or should be kept in mind. Other DDs can be any other chronic illness. So we'd ask for symptoms pertaining to any GI causes like any loss of appetite, any abdominal pain, malaria, hematochezia, any tuberculosis sort of chronic illness which is common in our population. We ask for any chronic cough or fever. He didn't have anything.
So excellently, you have covered that, but maybe malabsorption is another one which you need to
Yes, sir.
address that at that time.
Yes, sir.
And
Okay,
what
sir.
about the thyroid functions? Seeing these thyroid functions, besides these two diagnoses, any other thing which sort of comes to your mind?
Commonly, if TSH is high, it can be due to any interfering heterophil antibody, which can actually interfere with any of the thyroid function tests. So they all can be falsely high or falsely low when there are interfering heterophil antibodies, like can be seen in rheumatoid arthritis, like in even Graves' disease also.
Right. Go ahead. We'll come back to this.
Okay. Then since he was, so the DDs kept in mind, both red as well include the Tsh Oma versus resistant thyroid hormones. So because he was presenting at 64 years of age, so elderly person, so the Tsh Oma should be kept higher up on the list than RTH. So we had asked for the rest of the pituitary profile, which showed a low ATM cortisol and low testosterone. So this was suggestive of multiple pituitary hormone deficiency as well. The next step was to ask for an MRI cella, which is shown in the images. It showed a well-defined, heterogeneously enhancing, mildly lobulated suprasellar mass, which was heterogeneously enhancing on post-contrast view. It was a large mass, 4.7 into 3.8 into 3.1 centimeter, and it was appearably compressing the hypothalamus inferiorly, involving cellular floor, and abutting the optic chiasm, and also involving the bilateral cavernous sinus. So it was a large suprasellar mass, probably pituitary adenoma. So next, an ultrasound neck was also asked for, since the Tsh Omas are also known to stimulate the thyroid and also cause uni or multinodular goiter. This showed a small, the lobes were fairly normal in size. It just showed a small solid cystic nodule measuring 2.8 into 4.5 millimeter of thyroids 1. That's all. So after the imaging investigations and the biochemical parameters, we came to a final diagnosis of TS secreting pituitary macroadenoma with multiple pituitary hormone deficiency with a thyroid nodule of thyroids 1. So that's the end of the case discussion, sir. Next, we're moving on to the discussion part.
Yeah. So, Dr. Lavanya, if I may ask you before we move to the discussion, right? So, what is sort of so you have a classical case where you have a large TSH Oma, but what about other sort of associations or co-secreting hormones in such cases?
So 25%
for that.
Yes, sir. 25% of macroadenoma will co-secrete GH or prolactin. So we had asked for prolactin, which was normal, so it was 7. IGF-1 was not asked for.
So what is, you must have read about this. So what is about growth hormone co-secretion with these tumors?
So
maybe you'll talk discussion also about this.
So, yes, sir. So they can also have acromegalic features, which may mask the features of, we may mistakenly diagnose as acromegaly without realizing it's also TH secreting tumor, because it may mask the features of thyroid hormone excess also. And the treatment, like somatostatin analogs, can work for both the TSH part as well as the growth hormone part.
Yeah, so it would be worthwhile to have a GH in these patients.
Yes, sir. Yes, sir. Definitely.
Considering this. And what about the syndromic associations? Are they known? in such patients?
These are very, very rare tumors, sir. So they have been reported cases with men one, but very rare compared to the other hormone secreting tumors.
Yeah, so as such, these tumors are very rare, but I mean, one may not, one should at least look for, because as it is, you don't see these tumors very often.
Yes,
so
sir.
not to miss the syndromic associations.
Yes,
Go ahead, please.
Bonnie, may I ask a question?
Yes, sir. Yes, ma'am.
When you said rare, could you tell us which are the most important and the percentage of, like occurrence, which is the most common pituitary tumor followed by in decreasing order?
The most common hormone secreting will be GH secreting, ma'am, followed by Cushing syndrome. Then the gonadotroph adenomas also will come in between. And the last, the rarest is the Tsh Oma.
I thought the most common pituitary, no, are we talking micro, macro, or you're focusing only on macro right now?
If it is micro, what is it?
Yeah, micro. I thought
What
that
is
was
the commonest one?
Micro with prolactinoma, sir.
Yes, correct.
Yeah, that.
Overall,
I would have started with prolactinoma first, right?
Okay.
The most common is prolactinoma.
Okay.
Okay, no, that's fine. Go ahead.
So moving on to the management of this patient, he was planned for surgery. Pre-op management, for pre-op management, he was given carbamazole 10 mg 3 times a day, and because he had high raised thyroid hormones also, and he was planned for surgery. He was also started on tabcabergoline 0.5 mg twice a week, and since his ATM cortisol was low, he was started on tabhyzone also 5 mg 211. And he was asked to review after 2 weeks and to be planned for surgery. Moving on to the further management, he underwent transnasal transsphenoidal decompression of cellular component of the adenoma. After surgery, surgery of post-op period was fairly uneventful. He had no post-op DI. Since they could not remove the tumor entirely, so he was continued on carbamazole post-op, and he was planned for a resurgery and planned for transcranial resection of the tumor. However, patient was not willing for resurgery and so was discharged at request. So this was the HPE of the tumor, which was consistent with pituitary adenoma. And then that was about the patient's case. Next will be the discussion part.
Yeah, before you move on, maybe I missed it and you must have talked about it. What was the fundus and perimetry for this patient? Tumor.
Yes, sir, I didn't mention it in the slides. Fundus was normal. Perimetry was showing superior quadrant anomia.
Yeah, that becomes irrelevant. Go on, please.
Okay.
Bonnie, when you mentioned the investigations or the differential possibilities of weight loss, I assume all those investigations were done, right?
Yes, ma'am. All the regular routine, including CBCs, RFT, LFT, the RBS, HB1C, everything was done. All were normal, ma'am.
Okay, everything was X-ray chest.
Everything was normal. Normal. Only I've only mentioned the relevant ones in the slides.
That's fine. Go ahead.
Yes.
And suppose, Dr. Bonnie, if we sort of didn't have these associated multiple pituitary hormone deficiencies, what further approach would you have taken besides going for an MRI?
So in case we didn't find adenoma in the MRI, sir, then we should definitely do further test differential between Tsh Oma and resistant thyroid hormones. So further tests may include measuring the Shbg, then measuring the beta cross labs, then other dynamic tests, invasive, tests like T3 suppression test or Trs stimulation test or suppression with somatostatin analogs, all should be done. But in this case, since we found a very large mass, so it was not deemed necessary to go for the other DDs.
Yeah, and I'm sure we are unable to do many of these tests.
Yes, sir.
Only some of these actually which are there. But
Yes,
what about microadenomas in TSH omas?
They're usually macroadenoma. They're usually large and invasive at the time of diagnosis because they are usually diagnosed at a later on. They have a very insidious progress. So they are diagnosed only after they have probably reach a size large enough to cause mass effects.
Right.
And because they also don't have very toxic symptoms like Graves' disease, so they may not be diagnosed early.
Yeah, but is their incidence sort of, increased over time, over the years?
Yes, sir. Probably because of more earlier MRIs or MRIs done for other diseases. Maybe instantly picking up the pituitary tumors also.
Right. Go on with the discussion and maybe we'll come back to this.
Okay. So the syndrome of inappropriate secretion of TSH was the term coined initially to indicate two forms of central hyperthyroidism. That is TSH secreting pituitary adenoma and resistant thyroid hormone action. So moving on to the features of Tsh Oma, that is the differentiating features compared to the other commoner pituitary macroadenomas. They're usually large and invasive lesions and are very fibrous, so they're hard to remove. Like in our case, 20-25% of Tsh Omas are mixed adenomas. They are characterized by concomitant hypersecretion of other hormones, including mainly GH and prolactin. They may have had a long history of thyroid dysfunction and are often misdiagnosed as Graves' disease. About 1/3 of them will have had a history of inappropriate thyroidectomy or radioiodine ablation also, since they are often misdiagnosed as a commoner Graves' disease. The clinical features of hyperthyroidism are inappropriately milder than expected, as in our case. The deleterious effects of thyroid hormone or excess on the heart are less frequent. Because of the chronic TSH stimulation, they can have, majority of patients will have uni or multinodular goiter. In our patient, it was only a tiny small nodule. Recurrence of goiter is frequent after partial thyroidectomy, which may have inadvertently been done. So moving on to further discussion. So the commonest test ordered for initial screening of thyroid dysfunction is TSH. However, there are some conditions which are not that uncommon, which are in fact fairly common, for which if TSH alone is measured, it may be misleading. For example, recent treatment for thyrotoxicosis, in which TSH may remain suppressed even when thyroid hormone concentrations are normalized. Then any non-thyroidal illness, then TSH assay interference, then central hypothyroidism, including hypothalamic and pituitary disorders, in which the thyroid hormone, maybe the Ft3, Ft4 will be low compared to TSH. So if TSH alone is done, it may be misleading. Then similar to our case, a TSH secreting adenoma, then resistant thyroid hormone, or any disorders of thyroid hormone transport or metabolism, which is why an initial test should always include a thyroid hormone as well.
Bonnie?
Yes, ma'am.
Will you be going into details of each of these differential possibilities, or?
Yes, ma'am. Yes, ma'am. I'll be going.
We'll be coming to that. Okay,
Yeah,
thank you.
yes.
Go ahead, please.
Yes. So this shows the 7 major patterns of Tfts. So the center one, that is the normal thyroid hormones and normal TSH, and the common causes like hypothyroidism, which fit into the classic pattern of high Ft3, Ft4 with suppressed TSH, or low Ft3, Ft4 with elevated TSH, fitting into the classic hyper and hypothyroidism. Then there are other also not uncommon. There are also common patterns which do not fit into the classic expected relation between TSH and thyroid hormones, which may include a normal Ft3, Ft4 with suppressed TSH, a high Ft3, Ft4 with normal or high TSH, normal Ft3, Ft4 with elevated TSH, and a low Ft3, Ft4 with normal TSH. So I'll be moving on to the a few DDs for the same. So for a patient who has a normal Ft3, Ft4 with suppressed TSH, it can be subclinical hyperthyroidism, whether only the TSH is affected in the current phase. Then any recent treatment for hyperthyroidism in which the T3, T4 would have normalized, but still the TSH is suppressed. Then any interfering drugs like steroids or dopamine can suppress the TSH. And non-thyroid illness, which can lead to a multitude of changes in TFTs, and assay interference, which can be there, which can lead to any of the patterns that are described in the slide. So another pattern will be normal Ft3, Ft4 with raised TSH. So the very, very common one is the subclinical hypothyroidism and also the levothyroxine replacement, especially in a patient who has poor compliance. So it may have normalized, so the TSH would not be suppressed, but because they're taking at the time when they come for the test, the FT3, FT4 will be normal. And drugs like amiodarone can lead to low FT3 with a normal or high FT4. Then definitely malabsorption should be considered. Any assay interference. The non-thyroid illness can also cause in the recovery phase when the TSH may rise up to even 20. Then any resistance to TSH also. The next pattern will be a low FT3, FT4 with normal or low TSH, in which it can again be non-thyroid illness syndrome. In the early phase of NTIS, the TSH, FT3, FT4 all may be low. Again, assay interference can also cause. Then central hypothyroidism can also cause. And also isolated TSH deficiency can also cause, though rare, it can cause this pattern also. And lastly, moving on to the pattern, that's the pattern that our patient had. That is a high TSH or a normal TSH with high FT3, FT4. So these are the DDs for the same, including any assay interference, any non-thyroid illness syndrome, and thyroid replacement therapy. If it's if the patient has taken a high dose prior to testing, it can happen. And any drugs like amiodarone or heparin can also cause this same pattern. Heparin, even heparinized sample or a patient taking intravenous heparin, if the sample is assayed, it can lead to this pattern. Then neonatal period. Then lastly, the DDs that I've mentioned, the Tsh Oma and the resistant thyroid hormone action. So all this are the DDs for the presentation in our case. However, since the patient was not having any other intercurrent illness, no any drug intake, so the DD would narrow down to Tsh Oma versus RTH.
So, Dr. Lavanya, if I may just sort of come in here. With regards to non-thyroidal illness, can you tell us the various patterns which we can see? So this may be important for the audience here.
Yes, sir. So the initial phase of NTIS can lead to suppressed TSH with a suppressed FT3 and increased reverse T3. In the later on, if the patient has a very severe illness, then FT4 will also come down. FT4, a low FT4 is also a poor prognostic marker regarding the primary illness. If the patient recovers from the primary illness, then the FT3, FT4 will normalize. First the FT3 followed by the FT4, and the TSH will rise. It may normalize from the low suppressed value, or it may go even to the hypothyroid range. The maximum level up to which it can go high is usually mentioned as 20 IU per m.
What about normal or even elevated free T4, free T3 levels?
Yes, sir. And though this is the commonest pattern, the low suppressed ones, it can also show any of the patterns shown in the slide. So it can also cause high FT3, FT4, but common are the suppressed.
So this is very important, especially in the very initial phases. If we are able to, if we get thyroid functions done in sick patients in the very initial phases, we may even get high values. So even in ICU patients, so we can get those values. Go on.
Okay. So as in this case, when we find an elevated FT3, FT4 with non-suppressed TSH, the first step should be to confirm the elevated FT3, FT4 by instructing the lab to do a two-step method. Two-step method is adding a wash step. The sample should be washed prior to the second tracer addition. So this can remove any interfering antibodies. Then the gold standard should be equilibrium dialysis, but it's not done in most of the centers. Then we can also confirm the linearity of TSH assayed in dilution. So if there are any interfering antibodies, when the sample is diluted, it will show a non-linear pattern of the TSH. So this will rule out any other interfering antibodies. Then another way we can also do is by adding a PEG also to the sample, polyethylene glycol to the sample. PEG respiration will also be tried to rule out any cases like macro TSH. Then we should definitely exclude any confounding drug therapies or intercurrent illness. As mentioned, heparin, amiodarone, then high-dose furosemide, NSAIDs, aspirin, all can interfere and cause falsely raised FT3, FT4. So any confounding drug therapy should be ruled out. Then once all this is confirmed that the TSH is definitely raised along with elevated FT3, FT4, the next step should be to differentiate between Tsh Oma and Rth, in which the few of the differentiating factors include checking the affected relatives. So if any affected relative has a similar pattern of TMT, it can be Rth since it's autosomal dominantly inherited. Then we can measure the alpha subunit TSH ratio, which will be elevated in the Tsh Oma and normal in the Rth. Also, Shbg can be measured, which will be elevated in Tsh Oma and normal in Rth because there is resistance to the peripheral actions of thyroid hormone. Another one that can use here instead of Shbg include the beta cross labs, which again will be elevated in Tsh Oma and normal in Rth. Then next, since imaging is very freely available, a pituitary MRI and CT will be very logical to look for any adenoma. Then the other tests which are not frequently done are TRH response, in which we assess the response of TSH to an intravenous injection of TRH. So it will be normal or accelerated in Rth, and there will be no response at all in TSH because there is autonomous secretion. Also, another test, which again is not frequently done, is T3 suppression, which again will not show any response in TSH because it is autonomous production, and it will show the TSH will be suppressed with T3 in Rth. Then another is genetic analysis to look for THR beta gene, which will be mutated in up to 90% of Rth and will be normal in TSH Oma. So these are the tests that can be used to differentiate between these two very rare disorders. This shows the yes, sir.
Bonnie, so which of these? So if suppose the imaging did not reveal things, and
Yes,
so family history would have become important. One.
Yes.
And which of these is actually available? So sort of we can do these freely.
Yes, sir. So the available ones will include sex hormone binding globulin and beta cross labs, which are those are the blood investigations that can be done, which is at least can be tried in this scenario. Then an MRI can be tried because it's very freely available, but the other tests are usually not done, sir.
So what about the microadenomas? So although we know that it's the macroadenomas which are the most common, but what about the microadenomas, because they also sort of have been reported?
Yes, even the microadenoma, in the microadenoma also, if the thyroid hormones are elevated, then because the peripheral action will be there, still Shbg and beta cross labs will be elevated, as long as thyroid hormones are high.
We have a question, I think, Dr. Banwal.
Yeah, Dr. Bayusha.
By
what about T3 suppression test? That's
IHC,
T3 is available, no?
Yes, sir, T3 is available, sir. Only thing, patient has to take it for 10 days, according to the protocol. That's all.
Sorry, I interrupted you, Dr. Bantwal, sir.
No, she answered the question. That's fine.
Yes.
So this is the protocol.
So the IHC part has been asked about. So would IHC be relevant?
IHC is very relevant, sir. Unfortunately, it was not done in our case. It's not done in our institute very commonly, but it's very relevant.
And what about
the as a part? No, IHC. What is happening is they have to pay an additional 10 to 15,000 more. So that's why it was not done. We have asked our neurosurgeons henceforth to include it in the package also, so that it will be a part, and we'll also be wiser also. We'll know what exactly is happening.
Yes, sir. But very excellent and interesting case. So any particular thing about MRI, especially for microadenomas?
SPGR sequence will be useful to pick up microadenomas.
Excellent. Go on, Dr.
So this shows the protocol for T3 suppression test. So T3 is available. It should be given in increasing doses from approximately around 20 microgram to up to 80 microgram, so to 100 microgram, an increasing dose over 10 days. And the TRH test should be done. So this will show whether the TS is getting suppressed or not. So this won't be suppressed in TSH Oma because there is autonomous production, but it will definitely suppress over 10 days in RTH. So another test that was not mentioned in the previous chart was a suppression test with somatostatin analogs. So then, since it's very commonly available now, long-standing analogs can be tried, like octreotide LAR or lanreotide autogel can be tried. Octreotide LAR can be given a dose of 20 to 30 mg/IM every 28 days for 2 to 4 months. It's a long test, so it should be done only in cases when there is no large tumor. The sampling can be done at 0 and every 28 days before the new injection. So it will show a marked decrease of FT3, FT4, and Tsh Oma. So since they respond very well to somatostatin analogs, this should show a very good response. And there is no response in RTH. So coming to the optimal treatment for TSH Oma, surgical removal is
just 1 minute, Bonnie.
Yes, ma'am.
Okay, so before you're telling us about the treatment, so can you just step by step tell us which investigations you would have done in which order, to get a clear-cut diagnosis of TSH Oma? I mean, given that you can do everything.
Okay, ma'am.
You understand? Just step by step, just
yes,
one, like an algorithm, but you're just telling us that algorithm.
Okay.
Yeah.
So the patient, we should suspect TSH Oma when there is a non-suppressed TSH with a raised FT3, FT4. Definitely the thyroid function test should be repeated and confirmed once more after excluding all the other commoner things, including any interfering drugs, or any intercurrent illness, or any lab, any assay problem, any assay interference. Once we have confirmed that the TSH is indeed non-suppressed with raised FT3, FT4, the next step would be to differentiate between the two disorders, that is RTH and TSH Oma. So among the around 7 or 8 tests that I've described, the ones that can be practically done include sex hormone binding globulin and beta cross labs. Then since MRI is very commonly available, the next step would be to go for an MRI, because in case it picks up a large tumor like in our case, then that will then we don't need to do any of the other complicated tests. So so if the MRI picks up a large tumor, then that will be the that'll be enough. In case the MRI does not pick up a large tumor, then we should go for the other tests. So since T3 is available and more available than TRH, the T3 suppression test would be ideal in case a large adenoma is not picked up on the MRI. And at the same time, we can also look for the family history in the patient. If any similar family history or any similar lab pattern in any of the siblings or the parents, then again that will end the diagnostic dilemma. So if there is no family history, there is nothing on the MRI, then the next step would definitely have to be T3 suppression test, and the next would be a somatostatin analog suppression test also, in case there is no tumor found out.
So, Dr. Bonnie, there is a message from Usha Agyari regarding the T3 suppression. So that's what she also refers to. But there's another question from Dr. Shinjan Patra. The question is, can the alpha subunit TSH ratio effectively differentiate between a TSH Oma and the resistance to thyroid hormone?
Yes, sir.
Apart from the other things which you have mentioned.
Yes, so alpha subunit and TSH was initially the molar ratio of more than 1. Anything more than 1 was shown to be in favor of TSH Oma. Would that was seen in the older studies. So the newer studies done have shown that you cannot have a definite cutoff as such. So that would not be a very useful test, I feel, sir.
Yeah, agreed. So the ratio is now considered not to be such a reliable differentiator between the two conditions. But yes, is there a caveat with regards to SHBG? So why does the SHBG sort of rise? One, and what precautions one needs to take in mind, because there are a host of other conditions which can lead to rise in SHBG.
Yes, sir. We should definitely rule out any other drugs, like any estrogens, any tamoxifen, any liver disease, So all this can lead to SHBG rise also as well. So if there are no other interfering drugs, no other estrogen use, no pregnancy, and no liver disorders, then SHBG can be an ideal test.
So what leads to this SHBG rise?
The action of thyroid, the T4.
Yeah, so we know that SHBG rises in thyrotoxicosis per se, right?
Yes, sir.
So any form of thyroid hormone action at the liver will lead to SHBG rise.
SHBG rise, yes, sir.
Okay, so there's another question from Dr. Rohit. If patient refuses surgery, then
Yes, sir.
what are the options? So it's regarding treatment. I think you'll be coming to the treatment part.
Yes, sir.
But before you come to the treatment, I just want to sort of, regarding the case, was somatostatin analogs used in this patient, and is there an advantage of using them? I think carbimazole is used.
Yes, sir.
Any precautions while using carbimazole?
Yes, sir. So somatostatin analogs is the ideal medical treatment. Even for prior preparation, it can also be used. However, because of the expense, patient was not affording for it, so we did not use it. Carbimazole can be used as a temporary measure just for prior preparation, because if it's used long term, it can lead to further rise in TS and further growth of the adenoma also. So it should definitely not be used for long term, but for just a short term prior preparation, it can be used instead of somatostatin analogs. And cabergoline can also be used instead of somatostatin analogs because it's cheaper, and D2 receptors are also present on the adenoma usually.
Yes, absolutely. So that is very important with regards to carbimazole use, because it can lead to further increase in size of the tumor. And already you mentioned that patient had visual compromise, but yes, it can be used in the intervening period before surgery. Go on.
Yes, sir. So the optimal treatment would be surgical removal of the adenoma, which is the first line therapy for this tumor. Approximately 60% of the macroadenomas may be cured with surgery alone. However, there is a high potential for surgical failure as well, because, as I mentioned, the Trs are prone to have a marked fibrosis within the adenoma. So it's hard to remove them. As in our case, when the cellular portion was removed, normally the supracellular portion should sink down and should be easily removed via the TSS. However, it did not sink down, which is why he had to have a transcranial surgery. It was planned for a transcranial surgery, in fact, but he did not undergo the same. And also it has frequent extra and paracellular extension because it is found later on. It has a very insidious progress. So it's found many, many years after the onset. So it's frequently invasive, which is why, again, another reason for surgical failure. So coming to the medical treatment, long-standing somatostatin analogs can be used, including octreotide LAR, lanreotide sustained release, or lanreotide autogel. It induces a reduction in TSH and alpha GSU secretion in almost all cases. It has a very, very good response. Circulating thyroid hormones are normalized in more than 90%. Goiter size reduced in about 30%. There will be a significant tumor mass shrinkage in about 40%. And even the vision will dramatically improve in 70%. So it is a very ideal treatment for someone who is not willing for surgery or is not medically fit for surgery. So in these cases, somatostatin analogs will be the first line of management. In patients who have a co-secreting adenoma, it can also resolve the acromegaly. The adverse effects include hyperglycemia and cholelithiasis. The next line of management, if the somatostatin analogs cannot be used in case of non-availability or the high cost, include dopamine agonists. The dopamine type 2 receptors are present on most Tsh Omas. Bromocriptine and cabergoline have been used, but there are mixed results with only partial TS suppression. There is definitely not such a good response when comparing with the somatostatin analogs. For prior preparation, somatostatin analogs can be used, which is the best modality. Anti-thyroid drugs, like in our case, can be used, but long-term use should be avoided because it can cause further TSS rise. Then for symptomatic management, propranolol can also be used. Next, moving on to the role for pituitary radiotherapy. Yes, sir.
Thing here. So I am not too sure about this, but our surgical colleagues sort of, when we use pre-operatively somatostatin analogs for other pituitary tumors, not the TSH Oma, their concern is that use of somatostatin analogs leads to more fibrosis and sort of hinders their surgical thing. Have you sort of, do you know about this?
Yes, sir. There are reports saying that especially in acromegaly, it can increase the fibrosis, but there are also studies in which surgeons have reported that it increases softness also. So it is both are there, sir, but more on the favor of fibrosis. But there are also definitely other studies showing increased softness also. So I don't think it's very clear cut.
Okay, so for the others pre-operative, because we have options, good surgical cures, maybe here we do not have such very good curative treatments, and somatostatin analogs sort of have dramatic improvement. So they are indicated initially. Go on, Dr. Mala.
Okay, sir.
I think we should finish quickly.
Okay, sir.
We're running behind time.
Okay, sir. Pituitary radiotherapy can be indicated if surgery is contraindicated or declined, or in case of surgical failure. The dose include 45 gray fractionated at 2 gray per day, or 10 to 25 gray in single dose. Then other experience with other modalities like proton beam and heavy particle radiotherapy is lacking. But however, in general, Trs Tomas are radio resistant. So lastly, moving on to the criteria for cure, the parameters considered include clinical remission of thyroid toxicosis, any disappearance of neurological symptoms, as well as any radiological alterations, the normalization of thyroid hormones, TSH, alpha subunit, or the molar ratio. However, previous thyroid ablation definitely makes some of these criteria not applicable because they definitely won't have normalization of thyroid hormones. Then undetectable TSH 1 week after surgery is likely to indicate complete adenomectomy, provided that pre-surgical treatments were stopped at least 10 days before. Otherwise, this criteria can't be used. The most sensitive and specific test for cure is T3 suppression test again, in which if T3 suppression test completely inhibits the baseline TRS stimulated TS secretion, then the adenoma can be said to be truly cured. So this is the best test. Lastly, the take-home points for this case. Tsh Omas are rare tumors, but still can be seen. We should suspect if raised TSH with raised thyroid hormones in a case of pituitary adenoma. Then close DD is RTH. Surgery is the primary modality of treatment. Somatostatin analogs are the optimal medical treatment of surgery is not indicated or is contraindicated, and anti-thyroid drugs can only be used for prior preparation. Thank you.
Well, thank you, Dr. Boni. And as Dr. Bantwal said, we are running late. So I think you have covered all the aspects. So over to Dr. Ganpati Bantwal sir for his final comments.
Yeah, thanks, Madhukar. Yeah, I think Lavanya did a wonderful job. So the most important thing I would always say is when you're getting the thyroid hormone test, get all the three, the T3, T4, TSH, or the free T3, free T4, TSH. Because always what has happened, especially when we want to diagnose a resistant to thyroid hormone, or for that matter, even a TSH secreted adenoma, we just do a TSH and we find it is normal and then we miss it out. At least here we have a T3, T4, which is high, so that you may get some symptoms, though the symptoms are not much. But for making a diagnosis of RTH, most thing, it's not only in India, it's everywhere. World over also the same problem happens. That's the reason I always tell first time, do all the three components. So that will be my take home for this case.
So,
Over to the organizers, please.
yeah, thanks,
next.
Dr. Madhukar. It was really fantastic. So, Dr. Ganpati, please be there. You are the chairperson. So we will go to the next session. That is so another interesting session. So Dr. Mohan Shenoy will be conducting the quiz. So we have questions for that. So Dr. Mohan Shenoy will be putting the questions through now. He's a consultant endocrinologist at Sri Gokulam Medical College, Trivandrum, and he'll be taking us through the quiz questions. And after that, we have one more session lined up. So please stay tuned. Yeah.
Good evening, madam. Thank you, ITS. Thank you, Haritha madam, for giving this opportunity, and thank you all the esteemed panelists and the chairpersons. So I think this will be an interesting quiz with 15 questions, and I think I have taken help of the IT team to do a fair process by a Zoom poll. So can I request the IT team to please put the dummy questions in case those who are logged in can.
Yes, sir. Yes.
Yeah. So I think the rules of the quiz are simple. In the next 15 minutes, we can discuss. We can actually go for the contest. That is, three winners will be automatically chosen by the Zoom software, and that it will be coming on the screen as pop-ups. And I suppose there will be 40 seconds for each question. So that makes it around 12 minutes, and remaining we will just discuss the answers after the case 2. Hope everything is clear.
Mohan, we can have less time. 40 seconds is too long.
Yeah. All are straight questions. If 30 seconds are also okay. So digital team, please.
So, sir, previously launched the dummy questions.
Okay, we will just toss the dummy questions. So far we have got 80 participants. Yeah. So you can just see here, the host and the panelists cannot vote, are not eligible. So you can just check whether options. Okay, the first question I'll ask is what is the capital of India? So you can choose A, B, C, D, E. So I think A will be Delhi, B will be Bangalore, C will be Calcutta, and D will be Kochi. So we can just check which is working or not. The first question will be like that, dummy question. The second question will be what is the organ which we are discussing today? That is, 1 will be thyroid, 2 will be pituitary, 3 will be adrenal. So there are 2 straight questions for you just to check yourself available or not. So like that only 30 seconds will be coming, and I think so you can just check whether it's working. IT team.
Yes, sir, it's working.
You are getting the responses from the.
Yeah.
Okay. Yeah. So you can see that. So. But still there are people who are telling that Delhi is, so I just thought a very funny question. So I think we'll go directly to the quiz. So I think the questions will come one by one in sequence, IT team.
Yes, sir.
Okay. So I think we'll have a good discussion. All the best, everybody. So once again, the questions will be very straight questions, chronological order. A stipulated time will be there. The questions will be locked. And finally, the decision of the team, organizers, and quizmaster is final. So all the best, everyone. So let us go on to the first question.
What I was going to say is that it is better that we share the screen so that the entire questions, some questions are long, which have not been accommodated in Zoom.
Okay, then I'll just share the screen once.
Yes, sir. And
I'll do that. I have on the system. Yeah.
Once sir goes to the question 1, then you can launch the poll. Launch the quiz.
So this once more, I'll just open this. Yeah, you can see this. So the first question is this one. Okay, I'll read the question for you. Name the famous artist who was credited to recognize the thyroid gland and thyroid disorders as early as 15th century AD. Options are A. Leonardo da Vinci, B. Michelangelo, C. Sandro Botticelli, and D. Anthony van Dyck. So I'll stop the screen now.
Yes, sir.
Okay. So can you launch the poll? Yeah, here only it's coming, no? Yeah.
Yes, sir. Some questions like question.
Okay. Now it's clear for me. So I think the users can read the first question. The same thing I won't repeat. So a time starts now. So I will also read the second question for you. It's a straight question. An equal sex ratio, male is to female, is described among which of these thyroid diseases? So it is from a JCEM publication, and I think there was a good literature on this. So I think those who are in the training period, I will definitely know this. So the options are A, IgG4 related thyroiditis. Option B, Hashimotoxicosis. Option C is autoimmune polyglandular syndrome type 1, or option D, which is fibrous thyroiditis. You can see the first question and second question.
Someone has messaged that they cannot see. Please choose the poll option. Then you will.
Yeah, you can choose the poll option. Yeah.
Answer.
Yeah. Dr. Robin sir from Nepal, I think he knows all these, but I think just for information, maybe he has. So I will just maybe I can share the screen for you also in case you're not seen it. I will do that. So I thought this is a good change from the routine webinar type. That's why I did tried this. Okay, I will just, yeah, you can see. Second question you can see here. You can choose the poll option and then you can go for it. So next question, can I go in? Yeah. So third question is, name the drug which produces black thyroid due to accumulation of pigments. Again, the options are given in front of you. Option A is minocycline. Option B is paracetamol. Option C is amiodarone. Option D is chloramphenicol. So again, you can see the poll once more. IT team. Can I have a response from you?
Yes, sir.
We can launch the poll again.
We can't see the poll on the screen.
Yeah, that's what I'm asking them.
IT team, can you please?
Ma'am, the poll is already launched, and
yeah, people can already launch see it from their own systems. It's actually individually seen. It's individually seen. Dr. Robin sir has mentioned that he can see the poll now.
Yes, I will request you to keep the screen on so that from there you can just keep moving to the next question.
Yeah. So that's what I wanted a confirmation in that way. Okay, I'll then open the screen from there and you can read from there only. Okay.
Yes.
I'll do that. Because it just takes less time when we read like that. Okay. So fourth question I'll read out. You can also see every question as when you're on the poll itself. Okay. Quiz 4 question is the iodine content in amiodarone is dash. Options are A 17%, B 37%, C 57%. Option D is 77%. It takes only less than 10 seconds for that, but still, if you want to just be sure, you can always take time and answer.
To the attendees, you need to scroll up or down to see different questions. Poll the question 1 right now, if you are seeing on the screen, please scroll so that you can see all the other questions below.
Yeah. It's clear for everybody. I think I can also see that, but I cannot poll on it because the hosts and the panelists are barred from polling. Okay. So question 5 is, which among the following is unlikely in a patient with thyrotoxicosis factitia? So options are A, tachycardia with high T4 to T3 ratio. Option B is absent uptake in thyroid bed in nuclear scan. Option C is increased thyroglobulin levels. Option D is normal thyroid in ultrasonogram. So you can see the options. You should choose the unlikely one, which is false among these. So among these 4, 3 are true and 1 is false. So you can poll on it. So question 6 will be, cribriform morula variant of papillary thyroid carcinoma is associated with which of the following genetic syndromes? Option A is Carney complex. Option B is Werner syndrome. Option C is familial adenomatosis polyposis. Option D is McCune-Albright syndrome. So again, this is a recently described thing, and I think we are all familiar with this. So I think again, it's a straightforward question. Question 7 is a clinical scenario. A 30-year-old gentleman presenting with weight loss, even raise of temperature, neck swelling for 2 weeks, short duration, we can see severe neck pain radiating to the ears, tender goiter, thyroid function shows T3 240 nanogram per ml, it is slightly elevated, T4 is 16 microgram per deciliter, again a slight elevation, the normal range is 12, another one is 180, and TSH is suppressed, less than 0.01, and the ESR is also high, 90 millimeter per hour. Ultrasound shows, neck shows 2 nodules of 1.5 into 1 centimeter and 0.8 into 0.6 millimeter, and with also macro calcification. So Trs comes to 4. So what is the most likely diagnosis? So the question continues. Options are given in front of you. Option A, is it a toxic multinodular goiter? Option B, is it subacute thyroiditis? Option C, is it acute suppurative thyroiditis? Or option D, is it acetotoxicosis? The past history is not given, but definitely the past history was not significant. That's a clue. So we have 8 more questions to go in the halfway stage. So we'll just go because you can all see in the poll. So you can all vote on it, take your time. So question 8 is name the deiodinase enzyme subtype predominantly present on the placenta, protecting the child also growing fetus from the T3 and T4 excessive. So options among these, you know, there are 3 subunits. There is either option A, which is type 1, option B, it is type 2, option C, it is type 3. Again, option D, none of the above. It's a basic brush up of physiology, and we know that growing fetus requires the thyroid function, the mother's functions also. So we can see this is how the question 8 goes. So 10 seconds more, you can just see. Question 9, which among the following may precipitate a thyrotoxic storm? So I think this is the ideal situation which we are telling. So A option is paracetamol overdosage, B aspirin overdosage, option C it is morphine overdosage, option D it is thiacyclic antidepressant overdosage. So it's a very much described clinical entity which triggers thyrotoxicosis storm, and I think you all will be familiar with it. So this is again a straight question for you. So the fastest finger also wins. So I think you should vote on right time because I think it is automated software. So I think that what are the key I have given will already be shown in the software also. So option 10, the question 10, which among the following medication associated with thyroid function, which is mimicking the status of thyroid hormone resistance? So we had a case scenario describing the same. So already Dr. Lavanya has given some clues. So you can see the options here. Option A, it is cholestyramine. Option B, it is enoxaparin. Option C, it is lithium. Or option D, is it estrogen? So polls are visible in front of you whenever you are checking the poll feature. So I think you can answer any question within that stipulated time. So I will go to the question 11. What percentage of patients with Graves' disease demonstrate a positive anti-thyroid peroxidase antibody status? You can see the options, they are long. So option A, 15 to 20%, option B, 40 to 50%, option C, 70 to 80%, or option D, 95 to 100%. So it's from Williams. So again, don't check Williams now. So you are familiar with it clinically also. So please vote on it. Options are in front of you, either option A, B, or C, or D. So 4 more questions to go. In patients with acute psychosis, which among the following is the commonest thyroid function abnormality? So we know there is some entities which are already known, which are non-thyroid illnesses. So we should identify which is the more common, and that too with patients with acute psychosis. So it's described in clinical literature. The options are again option A, high free T4, option B, low free T4, option C, high TSH, or option D, low T3. There may be more than one answers which will be true, but we should identify which is the more common among these. So there is only one among these which is very common in this situation. So the 13th question, which of the following body fluids has a 50-fold lower concentration of thyroid hormones and metabolites compared with the serum? So again, a basic physiology question. I have taken it from DeGroot. So option A, it is either saliva. Option B, breast milk. Option C, urine, or option D, cerebrospinal fluid. Again, straightforward questions, non-controversial. So I think you can take your time and answer. I think there are at least 5 more minutes in total to poll to end. So you can vote on it. So the 14th question, second last question. The presence of which of the following clinical features has minimal or no impact on the risk of development of postpartum thyroiditis? So again, clinical risk factors have been described by Werner Ingbar. So you can see here, there are 4 options. Option A, age more than 35 years. Option B, type 1 diabetes mellitus. Option C, family history of thyroid disease. Option D, previous postpartum thyroiditis. So we have to answer which has minimal or no impact. So among these, we should select the less important one. Time is running up from the question point of view, but not the poll will continue for some more time. The 15th question is a clinical scenario. A 36-year-old male referred for thyroid clinic in view of incident-detected thyroid nodule increasing in size over 6 weeks. Background history of Hashimoto thyroiditis diagnosed 2 years before and was on 75 micrograms of thyroxine. On examination, he had a firm 1.8 centimeter right side nodule with enlarged lymph nodes in cervical region. Thyroid functions were within normal range. So the biopsy was done, and I think that the FNAC was showing category B. It is a FNAC was Bethesda category C. That is, you can see 3 biopsy results also confirmed a follicular carcinoma with a vascular invasion. So the question, the tail will be, which among the following markers is a poor prognosis in patients with differentiated thyroid cancer? So option A, it is age group 20 to 40 years. Option B, it is a tumor size. Option C, is it a male gender? Or option D, which is a Hashimoto thyroiditis. So again, it's a straight question for you. So the clinical scenario I will repeat for you. 36-year-old male referred for thyroid dysfunction, and you can see there was a nodule which was incidentally missed, checked and got, and it is increasing gradually, and you can see that it is firm, and again features suggestive of category C in the category 3 in the FNAC, and it comes to biopsy of follicular carcinoma, and the options will be to identify which is the poor post prognosis marker for these situations. Option A will be age group of 20 to 40. Option B is tumor size. Option C is male gender. Option D is Hashimoto thyroiditis. So I'll stop sharing the screen. The polls are visible for you. IT team, I think we have got 5 minutes left, no?
Yes.
Yeah. So I charted the poll at 8:50, I think. So I think we can end at 2 more minutes from now. Yeah. We can keep scrolling the screen in polls to answer this. I hope the controversies are not there. 1 or 2 questions had some dilemma. Maybe that is important for selecting the winners. We'll discuss the questions in the answer key at the end of the discussion. So I think 2 more minutes are there. If anyone has not answered, please, you have the time left for you. One more minute is there. The poll will end after that once the organizers end it. So I think you cannot answer afterwards. Last 30 seconds for you. In case of a tie, we'll distribute certificates more. I think that will be ideal.
We don't mind. We don't mind. We're happy giving certificates. So long as they participate and they get the right answers, I think that's important.
IT team, are you going to end the poll now?
Yes, please. Over to you, Pramila.
Thank you. Thank you, madam. Thank you.
Thank you. Thank you. That was
Thanks,
very
Dr.
nice.
Mohan. Yeah.
Yes.
Please stay with us. You have to tell the question answers in the end. So please stay with us. So now we move on to the next session and the last session. And after that, we'll announce the winners of the quiz and the answers for the questions as well. So I welcome Dr. Mary. She is professor and head of Department of Medicine, CMC Ludhiana. So she will be the moderator for the next session. And I welcome her to start the session.
Welcome, Mary.
Ma'am, your voice is not coming. Can you just,
mute?
Are you muted, or you can just increase the volume maybe? Because you are not showing to be muted. Maybe you can increase your volume. Your voice is not heard at all.
Can't hear you, Mary.
Yeah. We can't hear you at all. Either your mic is muted or maybe you increase your volume.
I think Pramila will go ahead with the case because
So we can start
I
the
will
case.
try.
In the meantime, Dr. Mary will just see her sound system. Maybe some microphone is off. Ma'am will just check it. So
we can't hear.
Yeah, we can't hear. So Dr. Ganpati, we can start with the next case, please.
Yeah, sure. Yeah. I think Dr. Vishwanath will present the case. Over to Vishwanath.
Yes, sir. The slides visible, sir?
Yes, visible, and you're audible.
Just make it full screen.
Please go ahead.
Yeah.
Good evening, everyone. Today I'll be presenting the second case. That's a rare form of hormone deficiency. So this is a 2-year, 1-month-old child who was the only child who was born out of.
Can't hear you well.
It's a case of 2-year, 1-month-old.
No, Vishwanath, we can't hear you well.
It's a case of 2-year, 1-month-old child.
I think you have to increase the volume further.
Dr. Vishwanath, if you're using earphones, I will request you to remove the earphones and talk directly into the device. Or if you're using earphones, then I request you to please hold the microphone closer to your mouth.
No, ma'am, I'm using the system itself.
Your
I think now
voice
it is
is
better.
very distant.
Okay, sir, it's a case of 2-year, 1-month-old child. He was the only child born out of non-consanguinity with a history of maternal subclinical hypothyroidism that was there in the mother, which was treated with levothyroxine therapy. It was a term gestation and was born out of LSCS. The indication for the surgery was non-progression of labor. The child weighed 3.5 kg and the child cried immediately after birth. However, there was no any history of neonatal stay, neonatal ICU stay, or any eventful perinatal period. The child was brought to the was taken to a hospital at the age of 6 months of age. However, mother had started noticing that the child had difficulty in breastfeeding since the first month of age and still had not attained neck holding by 6 months of age. She had also noticed history of sudden jerky movements, which involved both upper limbs. And the child was actually diagnosed with the global development delay by 6 months of age, but however, was put on conservative management and was asked to follow up. So due to no any improvement, the mother took the child to another higher center at the age of 11 months, where an MRI brain was done, which was suggestive of cortical atrophy. So with that, they made a diagnosis of global developmental delay with myoclonic jars. And he was treated with appropriate anti-epileptic drugs for 4 to 6 months. However, mother says she did not notice any improvements. For the non-relieving of the symptoms, the mother went to Nimans at the age of 2 years of age for the child, wherein child was evaluated with again MRI, which was suggestive of periventricular hypomyelination. And an EEG study was done, which was normal. And they noticed that the child had an abnormal thyroid function test. So that is when they referred the child to the St. John's from the Nimans. The child presented to us by 2-year, 1 month of age. At the time, the child had a -1.4 standard deviation score of height and weighed less than 5th centile.
Again, the head circumference was low. That's less than third centile. This is a growth chart where we can see it's falling on the 15th centile. Here in the photograph, we can make out that the child still has not yet attained neck holding, and he was speaking in only monosyllables. He could recognize mother and still had stranger anxiety at this point of time. The fontanelles were closed. We could see that the child had thin limbs, rectus carinatum, and pulse rate was elevated. We could see that the child had hypotonic posturing of all four limbs with jerky movements of the limbs, along with spasticity of all four limbs. And we could also see that the child had an exaggerated deep tendon reflexes as well, with an ankle clonus that was elicitable. The plantars were flexor, however, and the rest of the systemic examination was normal. So we went back and reviewed the old reports of the patient, where we found that the TSH thyroid function tests were done at 6 months of age itself, but TSH was normal. It showed a reduced free T4 levels and elevated free T3 levels. So even at the second visit at the higher center, there was elevated TSH with an normal total T4 and an elevated total T3 levels. So when we repeated it at our center, we found that the TSH was elevated with an reduced free T4 levels with an elevated free T3 levels. So here we have a clinical picture. Summarizing, here we have a clinical picture of a child with a global developmental delay, with an asthenic build with thin limbs, and who is low weight for his height, and still has not yet attained the neck holding as well, with the spasticity of the limbs and an elicitable clonus. So in the investigation wise, the brain showed important thing. The brain showed hypomyelinating disease in the periventricular region, with an elevated TSH, elevated free T3 levels, and a suppressed free T4 levels. So with these important bulletin points, what we could think about as a differential diagnosis as part of when we consider both the clinical picture and as well as the investigation wise. Clinical picture wise, global developmental delay and hypotonia, central hypotonia, the spasticity, and these things. These are the clinical features. With these, we can have, there have been certain syndromes that have been described due to PLP1 gene mutation or GLC2 gene mutation and MECP2 gene mutation, with the different inheritance pattern of X-linked as well as autosomal recessive. But the main distinguishing feature that differentiates from another differential diagnosis, that is MCT8 mutation, is that the normal free T3 and T4 ratios will be normal. So this is not falling into our clinical picture and investigation wise. And another close differential that can be there is MCT8 along versus thyroid hormone receptor alpha gene mutation. And this thyroid hormone receptor alpha gene mutation will have a similar clinical picture, however, with the delayed bone age. But again, the free T3 to T4 ratio will still be elevated, which will be same close differential will be MCT8 transport mutation. But again, an important differentiating feature from MCT8 transport mutation would be that there will be certain improvement with the levothyroxine therapy. Another significant differentiating feature will be that the MRI will be normal, whereas in patient with MCT8 transfer mutation, it will be hypomyelinating white matter disease will be there. So these are the four important close differentials that can be thought about while thinking about this case as well. So now coming to the differential diagnosis of MCT8 versus thyroid hormone receptor alpha, wherein it's an abnormal thyroid action disease with a normal TSH or a slightly elevated TSH levels, with a reduced free T4 levels. So here we can see that in patients with MCT8 transporter 8 mutation, there will be reduced free T3. Free T3 will be increased, whereas in thyroid hormone receptor alpha, again there can be reduced free T3, or there can be normal free T3 levels as well. But the reverse T3 levels will be very low in MCT8 transporter mutation, and it will be reduced in thyroid hormone receptor alpha mutation. So that is where differentials for reduced, decreased free T4 levels. If at all there is an elevated free T4 levels, again two differential diagnoses will come with an selenosistin binding protein 2 mutation, wherein there will be reduced free T3 as well. And other differential diagnosis is a thyroid hormone receptor beta mutation, wherein the free T3 levels will be increased in this disease entity. So with this differential diagnosis, we came to a diagnosis of MCT8 transporter mutation, that's Allen-Hurden-Dedler syndrome. So to confirm our diagnosis,
just 1 minute. Just 1 minute.
Yeah.
Yeah. What about when you said reverse T3?
Yeah, ma'am.
You see, that is important for the diagnosis.
Reverse T3, yes, ma'am. It can be one of the differentiating feature.
Okay. So, did you tell us what were your values and whether it was done or what?
No, ma'am. We did not routinely do reverse T3 levels.
Yeah, that's what I'm. Yeah, that's so. I think you need to clarify that.
Yeah, ma'am.
See, what are the specific indications when we really need to do it? Of course, we may not be able to do it. That's fine. But when should we really, yes, okay.
Congenital hypothyroidism, ma'am, like hepatic hemangiomas, consumptive hypothyroidism will be there. There we can find an elevated reverse T3 levels.
So what are the problems associated with testing, not able to test? There must be, some reason as to why we regularly don't do it. I'm sorry, Ganpati, you were saying something?
What are the other conditions where RT3 will be increased?
Yes.
Even sick thyroid syndrome also will have.
Yes, good. Yes, correct.
Regarding the testing?
Testing, I'm not aware, ma'am.
But you did not do that test.
We did not do,
ma'am. Have you ever done it or ever ordered it or asked, like it needs to be done?
No, ma'am. We have never ordered it as of now.
So, Ganpati, is there any reason for not being able to do it?
Availability issue, ma'am. It's not done in Bangalore, actually, if I'm not mistaken. We may have to send it outside to do the test. So that's the reason we haven't done it.
I know we read about these things, but there's always a query as to how to get it done, where to get it done. The when is clear. The when is clear now, but the other associations are always.
Like, for example, in the secure thyroid state, previously we were telling RT3, if it is high, it invariably says we are dealing with that. This one, but then now it's not so. Similarly, here we have the other one, global developmental delay. Plus, you also find that T3 is increased, the free T3. So that's the clue with the low TSH. With the low T4, free T4 or a T4, and TSH normal or increased slightly. So that's actually the clue with the global developmental delay. And the patient presenting features of both a mixed pattern. You also have a spasticity type and you also have hypotonia. So both the types will be there. So that's a clue for us. So in fact, it was picked like that. High T3 with global developmental delay and features of both, and also the periventricular demyelination. So that's how actually we started suspecting that we are probably dealing with this.
No, because I think this is, he's going to come to the literature and tell us how rare.
Yes.
Yeah, that's good.
Yes.
Go ahead, please.
Yes.
Very good.
Okay. So to confirm the diagnosis, we went ahead with next generation sequencing and analyzed the SLC16A2, that's MCT8 transporter gene on X chromosome. That was done. And we saw that the child had hemizygous missense variant mutation in the exon 6 of this MCT8 transporter gene in the patient. So now that we have confirmed that the child has this MCT8 transporter gene mutation, since it's an X-linked recessive pattern of inheritance, we did a Sanger sequencing to confirm the thing in the mother. We found that the mother was also carrier for the same mutation. So with this, final diagnosis was confirmed as Allen-Hurden-Dedler syndrome. So moving on to the discussion part. So this MCT8 transporter is a plasma membrane transporter which transports T3, and it's expressed predominantly in the brain, liver, skeletal muscle, as well as kidney. The different things are in the peripheral tissue. There are other transporters that can help in the uptake of thyroid hormones into the intracellular compartment, whereas this is not the scenario in the brain. So this is a picture in the peripheral tissue. wherein T3 enters either through the MCT8 transporter or T4 enters through the other transporter like OATC1C1, wherein T4 is acted upon by D2 to give a T3, which will be entering into the nucleus and bringing down the transcription effects. So it is unlike, it's a different in the CNS part, whereas there is differential expression of this MCT8 transporter as well as D2 and D3. So this MCT8 is there on the plasma membrane of the neurons and D3 is expressed in the neuron, whereas D2 and other transporter, that is OATC1C1, organic anion transporter 1C1, is expressed in the glial cell. So if at all the thyroid hormone has to T3 has to enter a neuron, it has to pass through the glial cell. So this deficiency of MCT8 will lead to deprivation of the CNS of the thyroid T3, that is thyroid hormone, leading to neurocognitive dysfunctions. So similarly, same here in the CNS, mutation of this MCT8 transporter will lead to deprivation of the CNS of this thyroid hormone, will lead to neurocognitive impairment. This is now the scenario in the periphery, wherein there are other transporters to take up this T3, which will lead to a selective peripheral tissue thyrotoxicosis, especially in the heart, increasing heart rate, liver, increased metabolism, again can lead to hepatotoxicity, skeletal muscle, loss of muscle mass will be there, and increased GFR. So it was first identified by Friesma et al. In 2003, and it's expressed only from the active X chromosome in females. So it is subject to X inactivation as well. However, this Allan-Herndon-Dudley syndrome was described even before the identification of the transporter gene. That is in 1944. And the syndrome that was described was the child had hypotonia, especially central hypotonia, with muscle hypoplasia, severe cognitive impairment, poor head control, dysarthria, and adenoid movements, and myoclonic jerks, as well as spasticity. It is seen that hypotonia and severe cognitive impairment are present in 100% of the patients. And few of the reports, they even say reduced fetal movements can even be picked up earlier. And prenatal and infantile hypotonia will lead to recognizable changes in the facial features, especially the lower part of the face, where there will be an open mouth and a tented upper lip. So this image where we can see there is an elongation of the face with a reduced bitemporal diameter and then tented upper lip and the drooping lower lip. So because of the peripheral thyrotoxicosis, we can have tachycardia, reduced QTc intervals, predisposing to arrhythmias. And it's one of the cause for a sudden cardiac death and increased mortality on such patients. And hypotonia will lead to hypoventilation, and risk of aspiration will always be there. As far as the liver is concerned, they'll be predisposed to hepatotoxicity and use of drugs, especially in this scenario, propylthiouracil has been tried. So in such cases, they might be predisposed to acute fulminant liver failure as well. The investigation wise, like already described, the free T3 will be abnormally high with a reduced total T4 or free T4 levels, and TSH will be in the upper normal range. So coming to the treatment options, the best available treatment for such patients would be use of currently is use of T3 analogs, that is triac, triiodothyroacetic acid, or DITPA, that is diiodothyropropyronic acid. That's because they do not require this transporter, that is MCT8, to cross into the neuron. And again, the controlled thyroid-mimetic activity could preferentially restore the normal function of the rest of the thyrotoxic organs as well. And again, the key to therapy is an early initiation of the treatment to prevent a permanent cerebral damage. And as early as intrauterine life also can be treated.
So how would you make the diagnosis in the intrauterine period?
Ma'am, since it's an X-linked disease, if the carrier state of a mother is already known, with the chorionic villi sampling, we can do as a part of
CV sampling, yeah.
Yes, ma'am.
But what time? Which trimester?
First trimester only, ma'am.
Was the mother known?
Ma'am.
Was the mother known? I mean, this was obviously not diagnosed.
This case was only when the child presented that the mother was found to be a carrier, ma'am.
Yeah. Okay, go ahead.
So, however, few people have tried levothyroxine therapy previously, but the central neurocognitive symptoms will not improve and will lead to additional peripheral thyrotoxicosis symptoms. And the other option that is tried is levothyroxine in combination in propylthiouracil. With this, there is effectively normalization of the thyroid function test. That is, the peripheral thyrotoxicosis can be controlled. There will be significant increase in the body weight that was lost previously, but the improvement in neurocognitive functions will not be there. Again, like I said, the propylthiouracil will again increase the risk of liver failure in such patients. And the future would be use of chemical chaperones to restore the residual MCTI transporter gene function that's there in such patients. And here is a list of treatment options that could be done. The chemical chaperones is still in the in vitro studies, in vivo studies still needed. Apart from that, they've tried intranasal thyroid hormone as well, but it was seen that they had, as expected, they'll have a peripheral thyrotoxicosis without any improvement in the neurocognitive dysfunction. And the gene therapy is the best therapy that can be done. It is still being tried in the zebrafish, where they've seen that there is restoration of the myelination in such studies. Combination of thyronorm, that is levothyroxine with propylthiouracil, we can see that the peripheral thyrotoxicity will be decreased, but the improvement in the neurocognitive dysfunction is not satisfactory. The other option is the DTPA, that's a T3 analog. There is improvement in the peripheral thyrotoxicosis, but again, the central nervous system, that is neurocognitive dysfunction, is still not at beneficial when compared to triac therapy. So idealistic is in the current scenario would be triac therapy with the amelioration of the peripheral thyrotoxic symptoms, as well as improvement in the neurocognitive dysfunction. And again, the key is that early initiation, because it's not a reversible damage. So as part of compassionate use program, the child was treated with triac therapy for 6 months. But however, due to delayed presentation and the logistic issues, he was started at 3 years, 11 months of age only. Started with 175 microgram per day and up titrated to 350 microgram with a goal to attain a normal T3 concentration. But eventually, he ended up discontinuing the therapy because again of the cost and also the availability issues as well. So with that, at the end of 6 months of therapy, when we did a thyroid function test, we saw that the TSH was almost normalized with an normalization of the total T3 levels and total T4 levels as well. So during the therapy, with just a 6 months duration of therapy, very short duration, but we could see that the child had a subtle increase in the stature as well. But however, the neurocognitive dysfunction was still the same. So this case was published in Lancet Diabetes Endocrinology as part of an international multi-center cohort study. So this was contributed from Dr. Belinda. And again, this was a disease characteristic description study. And again, for the outcome of the long-term therapy of T3 analog, again, this was also included in a JSM article that was published. So take-home message is, in a child with global developmental delay, always thyroid function test should be done at least once. Like sir said, all the 3 TSH, 3 T4 and free T3 should be done at least once. And sometimes only abnormality that can be seen is just an elevated free T3 levels. That could be missed if at all free T3 is not done. And once diagnosed, if at all affordability is there, early initiation is important to avoid further deformities, morbidities. Thank you.
Yeah. Thank you, Vishwanath. Yeah, this is a rare case, but then we shouldn't miss out these type of cases. Of course, in the tertiary care centers, we could find, and one of the clues will be a high T3 or a free T3 with a lower end of normal or low free T4 or a free T3, a free T4 or total T4, and TSH is normal or slightly elevated with global developmental delay. So just keep this in mind always. It's a very rare condition. It could be a lifetime event only. So you may get one in one's term, but then still you must keep this in mind. I think with this, I hand over to Professor Rita Bajaj.
So thanks, Dr. Ganapathy. Thanks for the session and those 2 interesting cases. We had very good discussion on that. So Dr. Mohan, would you like to now tell the answers for the questions and then we declare the quiz winners?
Yes, please.
Yes, madam. Yes, madam. I just opened my screen.
Okay.
think the IT team will be having the results of the winners, no? Yeah. So I will just discuss the questions and answers. So please let me just share the screen once more. Is my screen visible now?
Yes, it's visible. Go ahead.
Okay, I will just give my gratitude to the two senior quizmasters who have helped me in this, Dr. Vimal MV from Kozhikode and Dr. Tsh Oma, who are gracious to donate some of these questions to me. So the first question is a straight one. I think you know the answer. So this is Leonardo da Vinci. So it was in 1500 that he was first taught to depict the description of thyroid, and even the famous painting of Mona Lisa is thought to have some features of hypothyroidism. So the question 2, equal sex ratio, male to female. Anthony Weidman is a scientist who made this in one of his discussions, and it is APS type 1, which is the one which has been described, and I think it is already mentioned in the annuals in the Werner textbook. So the answer is the 2 is C. So again, the third question is regarding black thyroid, which this answer is option A, which is already described by JAMA in an article, and it's already in our textbooks. It is because of the pigments which are produced, and the close differential diagnoses are hereditary hemochromatosis and cystic fibrosis. So iodine content in amiodarone, as you know, option will be B, which is 37%. It's the reason why we are seeing thyroiditis being described, and also some conditions which we are known by amiodarone induced. So the fifth question is regarding thyrotoxicosis faticea. The option among this, which is wrong, which is option C, which is increased thyroglobulin level. It's actually in the low range. Absent range. So next is the fibriform morula variant of papillary thyroid carcinoma in the genetic syndrome. It has been discussed in the Mayo Clinic proceedings, and this is the description in which you are seeing the option C, which is familial adenopathosis polyposis, is described to be very much associated, and it is more seen in females. It is less aggressive than the other variants. And remember that there is a stain also available, which is beta catenin, which is staining strong for this. So there are two questions which are MCQable in this variant. So question C7 is a very straight question. It is a case of subacute thyroiditis. So option B is the right one. Then the quiz question 8, a deiodinase enzyme is a table in our textbooks, and option C, which is type C3, is the one which is the right answer. This is the table which shows you the various deiodinases, deiodinase 1, deiodinase 2, and deiodinase 3. Here we can see the placenta and the brain having deiodinase 3 activity. So they already mentioned there, which is why I took this question. Protects the fetus, it decreases the cellular T3. So we can see others are all increasing the cellular T3. So question 9, which of the following may precipitate thyrotoxicosis storm? So I think the answer is option B, which is aspirin overdose. And this is the reason. We can see aspirin, one case description, and one of the very important case reports showed there is no antidote to this, and it required hemodialysis in a case report very, very often, which we should understand, recognize. The reason for this is not understood, but salicylates can produce some displacement of the thyroid, and it's the reason that the toxicosis can occur, and the side effects can begin very low doses also. 2 grams is the ideal dose they are mentioned. Then the quiz question 10, the mimicker of the reason, which is option B, which is enoxaparin. Low molecular heparin can produce these features. So quiz number 11, answer the percentage of patients with Graves' disease producing anti-TTP positivity. The option C is the right one. 70 to 80% is the one. So we should remember that anti-TRAB is the more specific one, but anti-TPO can also be positive in Graves' disease patients. So 12 again, this is a slide which can have an overlap between option D and option A, but the description of the classical description is high free T4, which is the more common among variants. Low T3 can be seen in sick euthyroid and non-thyroid illnesses, but high free T4 is the one classically described as a common seen in acute psychosis. So question 13, I had mentioned that it is from DeGroot, and it is a very important one because cerebrospinal fluid is the tissue which is having the 50-fold lower concentration of thyroid hormones and metabolites. It's a protective mechanism, and this is one of the things why we should recognize that central thyroidism, also central hypothyroidism, can be seen. Question 14, the quiz is again a question regarding the postpartum thyroiditis. So option among these, A is the one which is having minimal or no impact. The option B, it's another autoimmune disease, so it's having an overlap disease. Family history is significant, even previous postpartum thyroiditis is also significant. So 15th question, the answer, again, it is a clinical scenario. The option C, which is the male gender, is described as a poor marker of poor prognosis. Other factors are important, but this option C is a marker of poor prognosis. So this is the answer key. For those who are interested in having a discussion or replies, please revert to us if any other options you found better. So I thank you for the kind listening. I hope the questions were informative and answers are also very useful to you. So the knowledge is immense, important, which is why we should always interact and discuss among this. Thank you, ITS, for the opportunity.
Thank you. Thank you.
Sir, I have shared the report, the result with you. If you can check that and then announce that.
Where is it? On the screen?
No, sir, I have shared it personally with you.
Personally, yeah. So I just saw it. I think I will just, shall I pass it on to Pramila madam, or shall I just declare it?
Okay, go ahead. Go ahead.
Thank you. Yeah. So according to the time limit, Dr. Pooja was the first one among them. 14 out of 15. That's a very good mark. So she answered within, I think, 12 minutes itself. So first prize goes to Dr. Pooja. Second is done by Dr. Afsar Fatima. She actually fared very similarly, 14 out of 15, and actually 2 minutes behind Dr. Pooja. So Afsar Fatima, congrats to you also. The third one is Dr. Manjunath. So he answered 12 out of 15. Again, a great thing to answer this much. And he answered in the same time as Dr. Pooja, but 2 questions less answered. So I think others who answered 12 were there. I will just name them. They will not get any prizes, but I think they participated very well. They are Dr. Praveen N, Dr. Pradakshna, Dr. Shruti R, Dr. Nikita Sriramamani, and Dr. Parth Jetwani, and also Dr. Vanishri.
But they'll get certificates. But they can
get certificates. Okay. Thank you.
Happy that they were there.
So I will just share this on the mail, ma'am.
Thank you, Mohan. That was very nice. Over to you, Pramila.
Yeah.
Thank you, ma'am.
I think with that, we come to the end of today's session, and it was really a nice discussion. And we thank the chairperson, Dr. Ganapati, for chairing the 2 sessions, and Dr. Mohan Shenoy for taking us through the quiz, and Dr. Madhukar and Dr. Mary for moderation of the sessions, and both the residents, they did a very nice job with Dr. Lavanya and Dr. Vishwanath. So with that, we end, and Dr. Sarita Bajaj would like to just say a few words, and then we end the session.
Yeah, so a very, very special thanks to you, Ganpati. I think your choice of cases and the time that you spent and the way you discussed the case as well with your comments in between, I think was excellent. Both the cases, extremely rare, but worth discussing. I'm sure, I think if we had actually opened the discussion, even amongst us, we could have carried on for at least another half an hour to 1 hour minimum.
True.
But I think you're a great teacher. It just reflects, because your residents have done a great job, and their presentation, I think, has really added to today's discussion. Thank you so much. Thank you to St. John's, of course, and of course Belinda. I think that was Belinda's. I think what you tried to highlight also, the Alan Herndon Dudley.
Herndon Dudley syndrome.
Yeah, absolutely. So that I think I won't go into the details at all. I think everything has been discussed brilliantly. And Mohan, thank you for those questions and for those answers. I think that's very important to be able to say as to why that particular answer is correct, rather than just yes, A, B, C, D, E. So I think that's extremely important. Thank you for that. Thank you, Pramila. You're always with us. It's very, very nice to have you. And your contribution has always been enormous. I think Minnie is with us also. I don't think Arun has been able to join us. I think possibly he's traveling.
Yeah.
And I think I saw Dr. Prasanna Kumar Lagan as well.
Sir is there. Sir is there. Yeah.
Yes. Ma'am, Dr. Menon was available. He has answered a lot of questions in the quiz, so he was available.
I'm not sure whether he's allowed to answer questions.
He is a panelist.
He's supposed to be a
Probably he
panelist.
attended as an attendee.
Anyway, then, well, he doesn't get a certificate for that, that's for sure. Anyway, so thank you to the digital team. Thank you, Ashmita. Good night. Good night. Till we meet again next week. Thank you.
ma'am.
Thank you so much.
Thank you. Bye-bye. Good night.
Bye. Bye. Good night, everyone.
Good night.
Good night. Thank you, ma'am.
Good night, ma'am.